we're going to talk more about opioids. Again, the issue around opioids is this. What would we do? I mean, imagine a world. Imagine, go back a few thousand years, because opioids have been around 5,000 years, at least we know of. But go back, not even that far by any means, to a world without local anesthetics, no less general anesthetics, no less opioid analgesics. It's not a world any of us would want to particularly live in. The amount of suffering would be extraordinary. But again, it's always about balance. It's always about making the right diagnosis and then monitoring and managing and mitigating risk. And you guys use very powerful drugs in terms of immunologics and other drugs. If you just throw those at people and say, come back and see me in a year and let's hope for the best, what do you think would happen? Disaster. What happens when the oncologist, he starts plug you in, start throwing some whatever, mycin or whatever in there, or I guess it's now the MABs, at you, and let's hope for the best. That's not the way to practice medicine. So if we're going to, and we do need to, we need to be the ones, all of us, familiar with and expert enough to understand when these drugs are appropriate, when they're indicated, and until such time as we get, and God, I hope it's soon, but there's nothing on the radar right now, a more effective, efficacious, potent, and versatile class of drugs in terms of serious, significant pain when other disease-modifying therapies don't work. Our job is to learn how to use these drugs as well as possible and mitigate risk. That's our goal, just like chemotherapeutic agents. We want and need better stuff, but we're not quite there yet. So let's talk about optimizing opioid therapy when it is indicated. I'm suggesting that it's when it's indicated. Now, in the time I've got, I want to talk about safe opioid conversion because this principle of opioid rotation is a very important one because of the genetic polymorphism, the heterogeneity of response that's pharmacologically and genetically now based, as we know. So we have to know how to move from one drug to another safely and not hurt people. And I do want to talk a bit about methadone. And if I don't quite get there because of time, I did at least want to include it in your syllabus so you can update yourself on everything we now know about methadone because we know a lot more than we did a few years ago. And methadone is a very problematic drug. If you didn't know that already, it's also potentially useful and has some value, but it's far, far more problematic than we ever believed before in terms of its potential toxicities and risks. And I want to share that with you. So what is opioid rotation? Well, it's switching or conversion. It's a change in opioid drug or route of administration with the goal of improving outcomes. And because this became and has become such an important and common practice in patients who have indications for chronic opioid therapy, starting with people with cancer conditions and severe advanced disease where the only relief they can get is through the use of opioids, and then select patients with non-cancer medical conditions or chronic non-cancer pain who are being followed very, very carefully in a comprehensive approach. Because if we're going to use opioids, it's only going to be as a component of an interdisciplinary chronic or complex, what's the word I'm thinking, an integrated, comprehensive pain management approach. If we think opioids are going to be a panacea, we've already should be stop before you begin. They're never going to be the panacea. So what this does is it subsumes the treatment principles generalizable to broad populations, but allows suitable flexibility for individual variation. We can't treat broad-based science on individuals. We can't generalize what we see from an individual idiosyncratic, perhaps, response, and then generalize that and think we've got the answer for everybody. That's where the errors, type 1 and type 2 errors, if you remember your statistics, come in. So we need a guideline that adheres to that principle. And the goal, of course, is to establish a regimen when it's indicated, and I'm always going to say when it is indicated, that is more effective than the prior therapy. We're not going to use opioid therapy if there's something more effective, safer, less costly, less in the long term problematic. We're going to reserve opioid therapy when that is all we got, okay? It's only one strategy to optimize opioid therapy. There are others, and more than one switch may be required. In fact, in prospective studies, when we're looking at very well-defined goals of therapy in terms of functional improvement, sleep, mood, et cetera, it may take 4 or 5 switches over the course of an individual's lifetime with the disease in order to manage and maintain effectiveness. And unfortunately, that's not generally what's done. So we have to think about that. So I'm going to refer now to the guidelines for chronic opioid therapy that came out of this very stringently applied process of creating an evidence-based guideline. I was a co-chair representing, this came out of a conjoined effort between the American Academy of Pain Medicine and American Pain Society. It was a very, by a scientifically stringent process where there were no commercial interests in influencing this. This was an evidence review. Roger Chow from University of Oregon Health Sciences was the methodologist that did the evidence review and the analysis. And the goals of this opioid rotation then is to improve effectiveness, which is different than efficacy and safety. Remember, all the drugs that we use are approved by the FDA on the basis of usually now 2 pivotal trials that demonstrate efficacy, usually in the short run, which is very different than the chronic disease populations we take care of, who we're going to look for effectiveness. That is this balance between therapeutic goods and adverse events over the course of years. That's what effectiveness is. And this is a whole different type of research that needs to be done to demonstrate that. But it means looking at activity, sleep, mood, social interaction, self-view, other quality of life measures over protracted periods of time. And we have a lot of clinical considerations when we're thinking about this. Obviously, the age, gender, race, ethnicity, because there are differences. Again, I alluded to genetic differences in mu opioid receptors. There are clearly a lot of genetic differences in metabolism now that we're finding. That again, we can generalize and say, for instance, that people of Chinese descent metabolize opioids very differently than people of non-Chinese descent and are pharmacodynamically more sensitive. But would that surprise you to know that there's a distribution of those responses across the population? So if you overgeneralize that, you may err for an appreciable portion of individuals. But it means you best start, if you're taking care of somebody with Chinese descent and now you understand the science, you're going to start perhaps at a lower dose. You're going to reduce the initial dose maybe by 25–50% and monitor and titrate to make sure you don't err on the low side. But that's, there will be, and probably over the course of time, genetic tests that'll guide us for a lot of the drugs we prescribe to understand the relationship between the individual and their genetic and the pharmacogenetics as it applies to the drugs we prescribe. There are disease-related issues, treatment-related issues. We're certainly not going to treat somebody who has severe sleep-disordered breathing and sleep apnea and start the same dose of an opioid on that individual and think that we'll get away with murder. We're simply not going to do that. We have to understand the relationship of the drugs and other diseases and problems people have, or we will cause great harms. And so on with other comorbidities, concomitant pharmacotherapy, the drug-drug interactions, which are many, and we talked about geriatrics, when people are on 8, 10, 12 different drugs, we better have somewhere in close proximity, because we can't remember all this stuff, right? It's like Conan Doyle said, the only reason Sherlock Holmes was smart because he only remembered what he had to, and he looked up everything else. And I think that makes smart doctors too. Of course, Conan Doyle came from a medical background, so he sort of knew this. But that means we better have something to refer to right at our hands, so that when we think about prescribing a new drug, we can look and see what is and have a good drug history, so we know what are the person's taking, what is going to be the effect on the CYP system. Are we going to induce the system, or are we going to inhibit the system, or are we going to compete with other substrates for those cytochrome enzymes, P52, 450 enzymes, and we're going to end up with more or less effect than we'd otherwise predict, or are we going to change the effect of another drug the person's on? It gets complicated. And the only way to stay up with it, thank God we've got little computers and PDAs and reference sources now, but they're imminently at your hands if you choose to use them, and I really recommend highly that you do. And so we've got situations from social sphere, adherence, risk, clinical fit, setting, finances. We've talked during the break extensively about what we're seeing in terms of risk, and we're talking about risk of abuse, misuse, and so forth that we have to be very concerned about. And we have to have a way of evaluating that. And fortunately, we do now have tools. And that's a whole nother lecture.